This panel is going to focus on women and COVID care and the gender inequities in healthcare, and particularly how those have been exposed during the COVID pandemic. So I'm going to go ahead and hand it over to our moderator, Dr. Cates, who will introduce our panelists and kick off the session.
Great, thank you so much, Camille, and hi, everyone. We're glad you're here, and I'm personally very happy to be able to be moderating this. My name is Jen Cates. I'm a Senior Vice President at KFF, the Kaiser Family Foundation, but also I teach a class at Johns Hopkins at SAIS, so it's exciting to be able to participate in an organization that I'm involved with in different ways. So as Camille said, this panel is going to be addressing a really important topic. The crux of the challenge is that women represent around 70% of jobs in healthcare, but lack better policies balancing work and family responsibilities. And women have played an outsized role throughout the COVID-19 pandemic. Despite, however, the dominance of women in the field, men continue to hold nearly 80% of the leadership positions. So among the questions we'll look at is how can we address the gender imbalance? And we have three excellent panelists. I'm going to briefly introduce them, who I'm going to talk with about this challenge. First, we have Roopa Dhatt, who is a passionate advocate for gender equality in global health and a leading voice in the movement to correct the gender imbalance in global health leadership. She's also a practicing internal medicine physician at Georgetown University MedStar Hospital in DC. And also probably for anyone working on global health issues and women know that she helped to co-found Women in Global Health in 2015 and is the executive director of that organization, which has nearly 24 chapters with more than 35,000 supporters in more than 90 countries and continues to grow. So welcome, Roopa. We also have Julia Kaufman. She's a research associate for global health policy at the Center for Global Development. Before joining CGD, she worked on global health research projects related to frontline healthcare and health systems strengthening in Rwanda, family functioning and child mental health in Kenya, maternal health and HIV care engagement in South Africa, and life skills interventions in Tanzania and the United States. Welcome, Julia. And then finally, we have Kristen Bergtora Sandvik, who is a professor of legal sociology at the Faculty of Law at the University of Oslo and a research professor in humanitarian studies at PRIO. She works on the digital transformation of humanitarian action and refugee management with a focus on legalization, accountability, ethics, and rights. And she's currently working on the technological, gender, and human rights aspects of the COVID-19 response with a focus on vaccination passports, tracking apps, and children's rights and the rule of law, issues that are very, very current right now. So welcome, Kristen, who will appear momentarily. So while we're waiting for Kristen to come on, I'm going to just start, and I have a general question for each of you, and we'll just start with Roopa in the order that I introduced you, but as we go on, we can go back and forth. So as I mentioned in the beginning with the statistics, public health is an industry that's dominated by women. All of us who work in it, we see that all the time. But there's this inequity in terms of leadership. And what kinds of challenges does that create for those of us who are working in the field and also trying to provide, whether it's care or analysis or whatever we do, as well as for patients, that there's this disparity. So Roopa, let's have you kick it off.
Thank you, Jen. There's so much that can be said on this topic, especially given my own personal background, but also the organization and movement that I get to be a part of and co-lead. But I'm going to focus on three main points. As already mentioned, women are the majority in global health, but they're clustered often into lower paid, lower status roles, and women's underrepresentation in health leadership impacts us at all levels, from lack of prioritization and funding for women's health conditions to exclusion of women from clinical trials when medicines are developed. And we can go on and on about the sort of ripple effect of not having women in leadership roles and their underrepresentation. This has multiple impacts upon women in health systems, but I'll focus on three key examples. First is on decision making. Evidence has shown that over and over again, when we have diverse teams, especially diverse executive teams, they outperform competitors that are run by men only. Research has also shown that when there are diverse teams, especially gender balanced teams, they're more likely to make ethical decisions. In health, there's no shortage of women in management pipeline globally. Women are the majority of nurses, midwives, pharmacists, dentists, and physicians under 40 years of age, but they face glass ceilings, sticky floors, and multiple barriers to accessing leadership equally to men. It makes sense that men will enrich it makes sense that women will enrich health leadership with perspectives based on different life experiences. And right now we're losing out on that expertise because most of those leadership roles are occupied by men, 75% in our most recent calculation. And more than that, since the default health worker is a woman, women are the experts in the health system and they in the health systems that they manage, but right now they're being marginalized and we lose out on this expertise. And COVID-19 is a prime example of women's expertise being left out. And we did a recent review of COVID-19 task teams, looking at 115 task teams around the world from 87 different countries, and found that 85% of those task teams were majority men. And UN Women just released a larger review of this, and the numbers again are consistent, showing that women are being left out of expertise and left out of these expert COVID-19 committees, and that's impacting decision making. And this isn't a marginal, it's not a women's issue, it's really everybody's problem because it impacts morale and quality of care. The second example I'd like to pick up on is really the pay aspect. We know that fewer women in leadership partly explains why the gender pay gap in health is around 28%, which is higher than most sectors. Most sectors have an average around 20%. So the health sector has an 8% higher gender pay gap, and this leads to lifetime loss of income for women. But the picture is much more bleaker when we factor in women's unpaid work, and we're hearing more and more about women's unpaid care responsibilities, especially during the pandemic year and beyond. But particularly in the health sector, women contribute $3 trillion to global health annually. Half of that, which is $1.5 trillion US dollars, is in the form of unpaid work. Over 1 million women in the country of India, for example, have been providing care to the COVID-19 response and are only receiving stipends that are not even meeting living wage levels. And the poorest women are subsidizing health care for all of us. And this is really a global issue that weakens health systems around the world. They have been carrying out essential identification of cases, briefing communities on infection control, and all of that fact that they are not part of the formal health system weakens the health system altogether. And finally, the other third point I'd really like to emphasize is one that we don't talk enough about is really women health workers everywhere report sexual harassment. We know that there has been a greater visibility that this issue brought forward with the Me Too and the Time's Up, but particularly in the health sector, we still have a lot to uncover and discuss these issues. It's a sector that is known to have very high rates of bullying and also sexual harassment from male colleagues, community members, and patients. Women in the health workforce are particularly targeted. And we know it is outrageous that the women who deliver health to around 5 billion people should be subject to such abuse, but it's not generally recorded or sanctioned. And there are many countries that don't have laws protecting women in the health workforce from this type of harassment. And we know that, if more female leaders were a part of the response at every level of the health system, there would be fewer cases of sexual harassment and therefore reducing harm to individual health workers. And this really does have a cost to our health systems for everyone as well. And my basic point is we all lose out when women are not in leadership. And these are 3 examples that I have highlighted. Thank you.
Thanks. Thanks, Roopa. You can see why Women in Global Health is such a successful organization because that was really compelling. Thank you. Julia, let's turn to you.
Thanks, Jen, and thanks to SAIS for having me and Camille for organizing. So I'll share 2 reflections. I think, firstly, if I were to speak on this panel as a white American woman, early in her career and talk about global health issues pertaining to women as monolithic. I think there's a very real risk that that would do more harm than good by contributing to the erasure of racism, bigotry, transphobia, whorephobia against sex workers, and all of the other deeply entrenched powers that be that intersect with gender. I think if we don't acknowledge and build recognition of the diversity of gendered experiences into health policies and programs, then we can never realize, or maybe redefine is more appropriate, the goals of what global health is meant to be. So, my second point is what this means in practice. And, Women in Global Health, led by Roopa, and Global Health 50/50, and so many other amazing groups and people do a lot of work to translate what I just described into practice by helping to ensure that people have a seat at the table and are present in meetings, and they assess, the presence and quality of policies on gender equality and board diversity and sexual harassment policies and so on through a lot of avenues. So I think what I'll add is more work on equity and health financing, looking at where it comes from, who it goes towards, who gets to decide how it's used, how do they approach those resource allocation decisions, and how can equity, including gender equity, be built in and incentivized every step of the way in terms of value for money and other considerations in how money is spent. And I think rallying around that could be really significant. So for example, Global Health 50/50 suggests that if organizations are assessed or self-assess on specific equity indicators, funders should support them in improving these and then use those targets for grant reporting. So that's just one specific way, but another would be to prioritize investments in local women's organizations and, adjust burdensome procurement and reporting systems accordingly. So I know Women in Global Health has been vocal about that as well. So overall, a lot is done, but I think a lot more could be done on transparency and accountability and health financing as additional levers for equity, including gender equity.
Thank you so much. Kristen, we'll turn to you.
Thank you. Thank you for having me. Can you guys hear me? Excellent. So it's wonderful to be here today and to listen to my colleagues here. I just want to add three sort of related points. And coming from a legal background, I tend to think that we should say more often that something isn't legal or that this is blatantly criminal. Right. So just picking up on the points, I think Julia said something incredibly important about sort of diversity, intersectionality, and sort of the importance of trying to look more places. And I think one specific characteristics of COVID-19 is that people in the most marginal workplaces have been kept mobile for the rest of us, right? So people doing the most dangerous care work, people fetching, sanitation, people working in shops, they've been kept mobile. The rest of us have been offered protection. And this is by default deeply gendered. So when you say, I like this quote, the poorest women are subsidizing the health care for all of us, not only out of their wallets, but literally with their sort of physical security. This isn't something that just happens, right? We have human rights instruments that we could use to frame this as not something that just occurs, but something that was strategic. And then the second one is on the culture of silence and the sexual harassment or worse. I come from the humanitarian field. It's taken a long time for us to talk about the fact that the most dangerous thing in the field might be your colleague for a woman nurse in a remote field office, right? So just the fact that we break this culture of silence and bringing cases to court is not very easy. I mean, we know this generally. It's going to be even harder for somebody who's going to take her colleague to court or even her boss. So I think this is something, we need to consider, the need for strategic litigation. But then we need to mobilize resources and be extremely careful and sensitive. Because although we would like to bring this litigation, the question is if the women we work with have the same interests, right? And the third one is this, how you organize your work. It just doesn't happen. You don't want to wake up one day and have 0 women in your task team, right? So there's something about how women are recognized as experts or just included as members. And I'm I've been working hard in the Norwegian response, and even here, it's, you wake up and the male professor has it again. So there's something about, naming these practices and trying to connect them to some legal standards, labor law standards, criminal law standards that I think might be helpful. But we need to be strategic and plan for the long haul beyond this pandemic. Thank you.
Thanks. I want to come back to that later, because I think what you're pointing out is that because these are such structural challenges, we need structural solutions, and attaching it to legality is one way to do that. I just want to let everybody know that we are taking questions. If you have any, please put them in the Q&A, and we'll be turning to those a little bit later, so please ask away. So just continuing from what we were talking about, and any one of you can jump in on this question. I think the main focus that we just had was more on the healthcare practitioner side. What about public health? And we're in the middle of a public health crisis, which is also a healthcare crisis. But what about public health? Do you think the gender disparities that we've been talking about exist at the same level? Are they less, or how does that play out? Does anyone want to jump on that one? Roopa?
I'm happy to chime in unless someone else wants to. But the numbers that we've been looking at women in global health for the last 5 years is really closely watching the World Health Assembly, where governments send chief delegates who head the country delegation, where majority of the global health decisions and public health decisions are being made at the global level. And what we've noticed is that those numbers have been stagnant around the 25% range. So the range has been anywhere from 21% up to 31% in the last 15 years. And that's an indicator of showing that even in a field such as public health, where there are majority women graduating, especially in the last 2 to 3 decades in high income countries, we're still seeing this plateau of 25%. When we've done the breakdown by region, what we have found is there are a few regions which have less representation of women, particularly Southeast Asia and the Eastern Mediterranean region have lower representation numbers. Africa at certain points in time have had higher, as a continent, higher representation. And what that shows is that a lot of the gender disparities when it comes to leadership roles and decision-making roles are consistent with what we're seeing in the health sector. As far as like some of the issues that I talked about, particularly the issues of bullying and harassment, we know that women in academia or within in university systems are also facing a lot of the same issues around bullying and sexual harassment, and that not being addressed. The gender pay gap also exhibits itself in the public health space, but particularly for women pursuing, and I hope my colleagues can chime in that have a bit more experience working in universities, but I also serve as an assistant professor at Georgetown University, and I can say women in academia in public health face a lot of barriers for career progression, getting tenure roles. A lot of the policies are gender blind. They don't factor in that women are, again, providing most of the care responsibility, whether it is for children, elderly, or just in a household itself. And so the peak years where women are in their reproductive age and supporting either childcare or elderly care is also the years where tenure track positions are being made, and women are often at a disadvantage. And there's been a lot of publications that have come out during the pandemic years showing that women have been hit hard when it comes to publications, whereas male colleagues have published a lot more and have been more prolific during this pandemic. And again, that has to do with a lot of the gender blind policies in the academia. But I'll turn to my other colleagues to chime in with more information.
Kristen, did you have something to say?
No, it's just on a personal note, when I was done at Harvard, we went home to Norway because it's the country of state feminism. So it's a country where when I was in law school, it was abysmal, but we have this sort of investment in women and childcare. And it's a very small country, right? It's like a neighborhood in New York, but it's doable. And I think as an experiment, Norway shows that this can be done if you want to put money there, if you want to put expertise there, and if you want to sort of lift women. So if nothing else, we exist in the world, and it's a lot easier for me to manage than I see a lot of my colleagues.
Go ahead, Julia, if you want to add to it.
Yeah, so just, echo what Roopa shared, and just to add a slightly different perspective and zoom out a bit, thinking about our SICE audience and thinking about other development institutions more broadly. I'll just quickly draw from some work that my CGD colleagues have done on how development finance institutions integrate gender equity into development finance. They conducted a really large survey of DFIs and found that significant efforts to incorporate a gender lens in DFI operations and process inputs aren't matched by the output measurement side. So the strategy documents don't translate into concrete performance targets and results measurement, nor is there, transparency about the share impact of gender-focused investments yet either. So, just to connect the dots beyond our health silo and recognize that gender policies fall short on translating into performance across different types of development partners. I think Global Health 50/50's organizational trackers show this to be true across almost 200 organizations, and global health entities and public health entities could be leading the way and setting an example on this front. But that's really not happening as much as it should.
Yeah, actually, one example I wanted to add around the sort of public health side of this is something that's happened during COVID-19 specifically, which is because the whole world has turned to epidemiologists and public health practitioners in a way that they never have. There's been a lot of, including young, new people in their career, being very outspoken on social media and on Twitter and being interviewed. And particularly the women, have suffered so much online abuse by putting themselves out there to offer their expertise. Often many of them are non-tenured professors as well. So this is like an entire second job or third job for them, and if they have families. And I've just noticed that it's really important to pay attention to, because it is a lot. People in public health tend to be in the background, and this past year a lot of us have been not in the foreground, and that's just another way it's played out, I think, in the public health space. Yeah. Go ahead.
I might just add to what Julia said, and I thought that was so important, Julia. The need to be extremely careful when you measure, when you standardize, when you look at inputs and outputs. So this is a field which has, it's partly being talked about in the UN out of goodwill, right? So we risk this being, just a series of buzzwords. So just having this hard-nosed approach, right? So this is about equality for the long haul, right? But insisting on this. I mean, from my own field, I've unfortunately seen that things are, we talk about this on Monday, and by Friday we have something real to talk about. So then we don't talk about gender anymore. So it's exactly what Julia is pointing out. Just have a very hard nose. This doesn't translate into English, does it?
I think we have it. So here's a question that sometimes people ask, and I think it's similarly, it's been asked in terms of race, ethnicity, and I think we can ask it in terms of gender as well, which is is there an impact on actual health outcomes for women, or for considering gender-based outcomes, but if healthcare practitioners are largely men? Similar to studies that have been documenting that when doctors are predominantly white, that can have a negative impact on their patients who are people of color. What are the risks there in terms of health outcomes? Since ultimately, at the end of the day, that is a big concern that we all have, right? Is to promote the best health outcomes that we can. Anybody want to talk about that? And I'll just
happy to chime in.
Yeah, please do. Please.
But I wanted to give somebody else a chance beforehand too. So we're going in the chronological order. There's, this area clearly needs a lot more data of what does it mean when we have women in leadership roles in health? What are the health impacts? It's a question that from day one when I co-founded Women in Global Health, we've been asked all the time. What can you give us the proof? What does it mean to have women in leadership? And one example, I know this question's about health practitioners specifically, but even if we take a look at the COVID-19 from a very bird's eye view, when we have seen, early studies looking at successful response by governments on COVID-19 transmission and reducing transmission. Women that countries led by women head of governments were outperforming at up to 6 times better outcomes. And I know that's, again, a very limited study, but there's something that was unique about the countries that had women head of governments and the women's leadership style itself that really played out in the pandemic, and it was being recognized, and a lot of discussions happened around, really understanding, what was unique to the leadership and to those countries that supported actually having women head of government. So there's, I think that's one piece to ground this discussion into, but specifically, diving deeper into global health, women in global health, we are making the case that there were some critical decisions made in the pandemic year that would not have been made if women were in equal leadership roles, and not just equal numbers as health practitioners, but that they were actually in decision-making roles and how the health system was operating at every level: national, subnational, regional, community. And what we are saying is that when women are marginalized in leadership, decisions are made that ignore the realities of women's lives, and that causes lasting harm and death. And there's 3 examples that I'd like to cite. One is the example of really disruptions to maternity services. WHO did a survey which found that 1/3 of countries reported disruptions to maternity services in the pandemic. Many countries have treated maternity and reproductive health services as non-essential, but women know that pregnancy does not stop for pandemics. Women have died because they cannot access safe delivery services, just as they have died in Ebola outbreaks for the same reason. And I do not believe that if a woman, or especially a midwife, was part of these decision-making bodies, that would happen. And it really didn't matter which country you were in, high income or low income. Women were being told to give birth at home and not come in for essential maternal neonatal care. A second example is that the stay-home policies, we've all heard numbers about gender-based violence increasing, and particularly those numbers doubling or tripling in many countries. And a lot of the lockdown policies really forced women and children to be in unsafe environments. And again, if women were part of the decision-making body on lockdown policies, they would challenge that. And finally, from a health worker perspective, we know that personal protective equipment has not been designed for female bodies. Health systems have been designed by men for men, even though women are the majority of health workers. And physical personal protective equipment has often been designed in a way where it's exposing women to increased infection, not designed for their bodily needs, and not having appropriate dignity, often too large in size. And as a result, women health workers have been exposed to infection, and this really has a massive impact. And in the early days of the pandemic, UNFPA actually sent dignity kits to Wuhan, China, when women health workers were being asked to work incredibly long shifts while they were menstruating and not having the appropriate dignity kits and menstruation hygiene materials that they needed. And so that's another example that, in 3 different ways, that if women were in decision-making roles in the health system at all levels, we would see different health outcomes, as well as gender realities for the health workers.
Anyone else want to add to that? Kristen? Yeah.
Yeah, no, and it's also still building on Julia's previous comments about financing. But for example, if you look at test regimes, right? So quick testing works fairly well now in a number of places, and my university has it for free. Other big entities do provide their employees and students and so on and so forth. So you can imagine a system where, pregnant women or women needing care were offered similar types of testing, comfortable, safe, discreet. And there's so many ways of organizing this, right, to make sure that women can access services, but it's not free, right? So we cannot offer women care if it's going to cost nothing, right? So there is something about putting this on the table, right? So I completely agree with the shocking fact of people giving birth, people helping them, not being seen as essential workers. But choices have been made here, and I do hope that we're going to be able to record these choices and sort of make sure we have a systematic overview of what actually happened, and then provide and articulate alternatives, but also pathways towards funding.
Go ahead, Julie, if you want to.
Yeah. So quickly, I think, it's worth emphasizing that everyone is worse off due to disparities in leadership, especially those who aren't represented, but it harms everybody to have limited lived experiences and expertise when making decisions about healthcare, because they're just, missing out on the collective knowledge and ideas that people have to contribute. One of the findings that CGD has been exploring a lot, including working papers by researchers in Uganda and Kenya, and I bring this up because this is due for a lot more legal work and structural policy changes, is significant increases in gender-based violence. So 3/4 of studies documenting this impact point to an increase in violence, and interventions to address the violence and support survivors require, it goes without saying, but diverse gender responsive perspectives and ideally lived experiences at all levels of decision making for effective programs. So just wanted to mention that example.
Great. And I was just going to add another thing that I think Roopa might have mentioned in her opening comments, but which is a little different, which is the exclusion of women or women in clinical trials, which is built into the design and therefore meant that pregnant people were not included in any of the trials for COVID-19 vaccines. And so at the end result, they put any of the regulatory authorities and the drug companies in this position of saying, well, we really don't have the data, but we don't think there's a problem. And it put the onus on pregnant people to make a decision that is a life or death, decision in lots of different ways. I happen to believe, and I think the recommendation was sort of put out in as strong a way it could without that saying, yes, these look safe and do it, but I'm sure there were pregnant people who might have made a different decision. And so that's just a very concrete example where the structural way in which those are designed is excluding pregnant people from trials. And so we're sort of a lag in understanding the impact.
Say, Jen, it's really, I'm really glad you bring up that point, because it's an example of, we keep making the same mistakes over and over again. So it's not the first, disease outbreak where women have been left out of clinical trials. In general, women have been left out of clinical trials. If you look back at, decades going back since clinical trials have been in practice, but particularly the Ebola outbreak showed that women getting vaccines had better health outcomes, and they actually had a better response to the vaccine itself. So it is alarming that we operate in a gender blind way, and in this case, actually gender harmful way, by ignoring and excluding women, and especially pregnant women from these trials. And so I would say that, in building back better, or building back more equal or newer, fresh, whichever language we're picking, but in this COVID-19 response and pandemic preparedness aspect, a prime example being gender responsive would be to include and make sure that all the data that's being collected is being done in a sex and gender disaggregated manner, but also that women and pregnant women are included in clinical trials.
Just jump in.
Yeah, no, I mean, you talked about all repeated mistakes, but I think we also had opportunity to make some new mistakes. So you guys in the US are doing better than most European countries in terms of vaccinating your population. But you also had a lot higher mortality. But what about these vaccination passports, for example? At least in Europe, this is going to regulate mobility. And we know that digital surveillance is fairly often bad news for women. And passports that are no longer just going to be passports, but something that regulates your rights in your own country as you access health services, your workplace, care. So this has a gender dimension to it, right? But we need to look for it, and we need to look for it now. And we need to try to influence how these passports are regulated. So if we fail to do this, we're going to wake up in a year and say, wow, this had a really bad impact. So there's something about trying to be ahead all the time, which is really hard, because I know you guys are working 24/7. But unfortunately, particularly the digital tools have risk. I just wanted to bring that up as well.
Yeah, can you talk more about that? Because I think all of us are probably thinking about this and trying to grapple with what it means. I know you're working on some of these issues right now.
So in the European Union, the EU came up with the idea for a digital green certificate, March 17th. And this is fairly typical EU. So they hope that by the summer, they're going to have sort of streamlined 27 national health systems, which is going to be fair. That's good news for the union if they can do it. But we have questions about access to vaccinations in the first place. We know that a lot of populations will not be vaccinated because they can't, because they want, but also because they're not offered vaccines. Mm-hmm. And then there's the question about what the passport is going to be used for and by whom, right? So this is about what happens to your health data, but the question is also what sort of data is eventually going to go onto that passport. So it relates partly to vaccination programs, but also to mobility and other rights. And it's because it seems like such a wonderful idea, and because the commercial impetus is so strong that we're really concerned. And right now, it's probably more obvious that this is going to have a harmful impact on homeless populations, migrants that don't have a legal permit, et cetera, et cetera. But also from a gender perspective, I'm concerned that we're going to wake up and find that there are some things that need access to that will work out very badly for women, for example. But we're going to see. This is going to happen quickly. And part of the problem is that a lot of countries have a tired administration, so things are not being democratically discussed. You just wake up one day and there has been no program for making a proper law, which is always bad news for women.
Anyone else want to comment on this issue of passports, COVID vaccine passports, or move on? Okay. Everyone's like, no, thank you. Okay. I mean, it's certainly playing out. That issue that you mentioned, Kristen, in the US is something we've been looking at as well, which is the real risk of perpetuating or even exacerbating inequities that already exist in what we've seen with the pandemic, as well as access to vaccines. So definitely an important issue. Can we you brought up in the beginning around international law and trying to use the legal system in ways to redress or address some of these inequities. Can you speak more about that? And I know in your work, I think you've made the argument that healthcare workers are being denied the international human right to the highest attainable standard of physical and mental health, as well as the protections guaranteed under the Convention on the Elimination of All Forms of Discrimination against Women. So, and in that case, international law can potentially be used to address that.
So thank you. So we've been through some of this already, right? So recognizing that the duty of sacrifice and the double burden of care at home, at some point, this becomes discrimination, right? At some point, the lack of facilities, provisions, or planning, it's not bad logistics, right? It's a violation of the right to work. And then this issue of documenting gender-based violence, for example, against health workers, investing the resources. So it's partly about, trying to create claims. And then it's the kind of normative framework you use, right? So CDOT, the Women's Convention, it's a document from 1979, could never have been made today. Most of it is fairly progressive, but not all countries have, ratified the convention, and it's just full of caveats, and many countries, do their best to undermine it. So I would suggest more comprehensive toolbox where you take that sort of international human rights law, international women's rights law, you take public health law, you take different conventions of labor, which might maybe in this case be most effective because they're seen as quote unquote not political, which of course is not true, but so there's this kind of layered and nuanced litigation strategy, but also that it doesn't mobilize itself. A couple of years ago, I worked in Colombia with internally displaced women's organization, and we did research, and they used the research to go to the Constitutional Court and put forward a tutela about their own health rights. And it didn't really work out in the sense that they got better rights, but they were heard and they got to put their claims forward. So we have to be patient. This is not going to solve itself overnight, but I do think that we should probably be tougher about strategic impact litigation. And I mean, I'm educated in the US, you guys are probably all in the US. So we have a lot of faith in the law to change things, right? But I think it would be interesting to explore in a different jurisdiction, maybe like the Ugandan, like the Colombian, if this could work. And call it, talk about this as what we talk about it today.
Great. I'm just going to say we have one question that's come in, so please ask, or we'll be able to turn to those soon. So if others want to ask questions, just put them in the Q&A. Does anyone else want to comment on the legal aspects of things, or using the law either in a positive way to address these, or otherwise I have another question I'm going to move to.
I just want to echo what Kristen is saying there about the fact that really looking for legal instruments, especially to ensure that women are in leadership roles. That's another example. This just 2 weeks ago, the Commission of Status of Women, the UN meeting that focuses on gender equality and women's rights, met, and the theme was around women's leadership. And there was clear recommendations made of having quotas and targets as part of government policy, asking governments, particularly when or political parties, when they are putting nominations forward, having gender equal nominations. Again, we're talking in binary terms, but of course we should be more gender inclusive and include all genders. But here are examples of where, if we want to address the structural barriers, we do have to create the policies, and policies are not enough for implementation to happen. And that's where having civil society engagement and other accountability mechanisms are very critical to ensuring that policies get implemented. And particularly one other convention that is up for ratification is the ILO 190 Convention on sexual harassment and ending all forms of violence and sexual harassment in both formal and informal workplaces for all genders. And that's up for ratification in June of this year. There'll be a big announcement around that. And most of the countries in the world have not ratified this convention. And that's another example of using global legal frameworks to advance some of these deeper issues that affect women in the health and care sector.
Great, thanks. I want to turn back to COVID-19 specifically again, and I think the one question that's come in is about that as well. So this is starting with Julia, question for you, but anyone else after that. So in thinking about the impact of the pandemic on women and girls specifically, I know you've done some work on this. What are some things that we've learned about particularly on the sexual and reproductive health supply chain side, gaps, weaknesses, issues that probably, once again, should be addressed now for the next pandemic? Maybe they will, maybe they won't, but can you talk a little bit about that side of things?
Yeah, absolutely. So, we've all read and heard a lot in the news about supply chain disruptions and how factory closures in countries in East Asia and South Asia create ripple effects for access to products around the world. Then I also want to link this to, so Cgd has also been tracking the economic effects of the pandemic on countries and households. And these economic crises have further implications for health. They feed into each other in a lot of ways. And one specific way is that in a lot of resource-constrained countries, many people pay out of pocket from their own income to access healthcare without government insurance, without donor aid to help. And this is especially true for contraceptives. I think 80% of contraceptives are purchased this way, out of pocket, with household income. So given the economic crisis happening in tandem with medical supply chain and broader health service disruptions and resource and personnel diversions due to COVID vaccination now, the risks really compound for sexual and reproductive health care and essential services writ large. So some work that we've been synthesizing at Cgd highlights that in many countries, access to contraception, antenatal care, facility deliveries, they've so far we're seeing that they've declined more than 10% during the pandemic. And this varies across countries, but in all countries going forward, the increased death and illness from missed preventative care and primary care, like routine immunization, that's likely going to be reported in months and even years to come. So, this 10% that we're seeing already and the translation into other sort of preventative and primary care is really concerning. It's not too late for action right now to alleviate longer term consequences. I think good data systems or better investments in data systems make it possible to track who was missed, target catch-up services. That's already happening a bit in Pakistan. So continuing to learn from innovations in service delivery, whether these are catch-up campaigns or integrated one-stop shop models or telemedicine, linking to the question we got, is really crucial to ensure that these programs or these adaptations to continue essential service delivery are gender responsive and that they're actually achieving impact and not further perpetuating inequities by missing the most marginalized. Because a lot of these telemedicine and other innovations, some are provided, they come from the private sector, and if they're not connected to public funding to help the most vulnerable to access them and use them, they're very cool and exciting, but they just risk worsening inequities.
Thanks. Yeah, so the question, thanks for getting to that question. The question was, while telemedicine in low and middle income countries has its challenges, since many communities don't have access to internet, et cetera, it has been used as an intervention during COVID-19 as a way for women to access sexual and reproductive health services. Do you all see this as a sustained push for the use of telemedicine post-pandemic, part to increase access, but maybe to provide flexibility for healthcare workers? And if so, what might this look like? Does anyone want to take that on a little bit more specifically? Kristen? Yeah.
I actually worked on the humanitarian technology side of this. So like Julia, this has been a field where, startups, social good entrepreneurs come and they have a solution. They just need a problem. And this is probably the perfect problem, right? So it's worthy. I mean, you can help women or children. You can help people being protected against violence. So we risk these sort of ad hoc interventions that are not really about, the best interest of the patient, for example. On the other hand, I do think that the community is maturing. We see this, at least in my field, across a range of sort of from, the interventions to protect people's health, to give them legal protection, to maybe bring some cases to court. That, these innovations help us collect and cure. But I think it's important that we stay critical and we sort of keep our focus. And something that I'm ambivalent about is the sort of global north innovations like Callisto or Legal Fling, where you can, have a blockchain agreement on your future sexual intercourse, or you can upload sort of your testimony about somebody who raped you. And, at the outset, this would seem like something for women in the global north. On the other hand, I do think that we should be willing to think creatively about these types of innovations. And then if we don't like them, we rethink it, but that we keep the discussion going. Digital health is going to be used across the board, right? So I think we just need to, invest time in this. If you permit, I have a new paper with the ICRC on sexual violence and technology, and I'll just put the link in the chat. It came out in March.
Thank you. Anyone else want to comment on this general question about the use of telemedicine, for example?
Briefly, I can comment on the experience here in the US. I've heard mixed results about it, in the sense, in many ways, It has increased access to mental health services, but only to those that are already insured. So we're not necessarily addressing the root barriers. And then for those that are in households where they don't have privacy, in a way, it also puts a lot more personal threats and personal risks into place. So I think it's, we can't have a sort of blanket approach to using telemedicine. Another example that is outside of the United States is that, particularly looking at the country of Pakistan, where women are educated in equal numbers or high numbers in health professional fields, particularly medicine, pharmacy, dentistry. Many of those women, as a result of telemedicine, have been able to continue their career. Usually after they get married, they've often been, because of the social norms and gender roles within that particular social cultural context, most women are often leaving the workforce, but through telemedicine, many of them have had chance and opportunity to stay. So I think, it really depends on the context. And, going back to some of the points that Kristen was really making, we need to do gender impact assessments of all of these, tools and technologies, and make sure we're not perpetuating gender inequities. And particularly when it comes to addressing health disparities, digital technologies alone are not enough. We really do need to look at all the different barriers that are impacting access.
Yeah, and just to chime in with one more thought, I think, the call for making sure there's equity in these innovations, I don't mean to be too skeptical about them. Like, I think the opportunity to harness entrepreneurial ideas, and especially from people in low and middle income countries close to the ground who understand the problems, getting back to the global north generated ideas, is really exciting. It's just giving it the effort to integrate into health systems so that they're sustainable and not just these one-off things that don't really make a scalable difference.
Great, thanks. I was just say from research that we've looked at, and also that I've been following, I think because of COVID, telemedicine is here to stay in a way that it never would have. It accelerated that move in the United States and around the world, and in some ways that has been quite beneficial. PEPFAR, for example, the President's Emergency Plan for AIDS Relief, had been wanting to use telemedicine more readily, and then all of a sudden had to. And so there are a lot of benefits there, but we have also heard the same concern that I think Roopa might have mentioned it, and certainly Kristen, that for people who don't have privacy or aren't safe in their home, it doesn't offer them that, it doesn't provide any extra benefit. So it doesn't mean telemedicine is bad, but it means it's not the solution for everybody. And so I think that's the theme we're all sort of highlighting. I don't see any other Q&A. So unless somebody wants to put another one in, I'm gonna sort of try to wrap us up a little bit and ask a couple like closing thoughts or last questions. Kristen, you mentioned that Norway is a good example of where things can be done in a new way. Are there other examples out there that anyone on the panel wants to sort of also highlight where there has been progress in some of these areas, whether it's at a country level or a region, regional or sub-regional? And then that's one question. And then to start thinking that also come back to everybody about like, if you had to make a recommendation or sort of a one take home, like what would be your first thing that you would say should be done? What's the most critical thing to address some of the gender inequities we've been talking about? So starting with examples, anybody want to offer any up?
Yeah, Jen, I can come in with one from a low-income country example, and particularly Women in Global Health has a campaign initiative called Gender Equal Health and Care Workforce Initiative. We just launched it this January with the government of France and WHO, and we're asking for particularly action on leadership, pay, safe and decent working conditions, and workplaces free from all forms of harassment and violence. And a country that I'd like to highlight is Ethiopia, from a very specific focus at looking at how they have formalized their community health workers. So Ethiopia, for those that aren't familiar, has a per capita health spend less than $800 a year. It's a largely rural population of 109 million people, and particularly Ethiopia has only recorded 3,000 deaths from COVID-19, and a lot lot of its success in the COVID-19 response, they have attributed to their 40,000 community health extension workers. What's notable about their community health extension workers is that, one, they are considered formally part of the health system, so they are considered formally health workers and get the benefits of being in the labor market and being formally in the labor market. The second thing that they have done is that they actually compensate their community health workers with decent wages and a living wage, so they're earning enough for it to be a living wage job. They're not unpaid, which is really critical because majority of the community health workers in the Africa continent and around the world remain stipend-based or volunteer-based. So this has been really critical to Ethiopia's response. And more importantly, they have not just left the community health workers in that state. They've also created a mechanism for career progression so that community health workers, who are again majority women, have the opportunity through further training opportunities to go up in the tier and have some, a career development at the community health worker level. And this has left Ethiopia with many benefits, including a health benefit, which they're able to address COVID-19, a economic benefit, since they're able to have greater economic growth by having formalized the community health workers and creating other health-related jobs, and the gender benefit as well, which is the fact that these are women that are now formally having much more economic empowerment as a result of this.
She said it all.
We're kind of close to, right, she did say a lot. And so we have like a minute or so left. And before I close this out, anybody want to just quickly offer, if you're going to be able to make change tomorrow, what would be or you do something to make change, what would it be? What would you select if you had to select one? I know that's a hard question, so you don't have to say one thing, but.
So I think, this panel has beautifully summed up how this is a social justice issue, right? It's about pay, it's about equal rights, it's about documenting, but it's also about, world making through the words we use, right? So if something bad happens to you as an entry nurse, your leadership needs to put the blame where the blame should be and organize the work properly. And I do think that together we can sort of push this forward. And just thank you so much for having me today.
Julia.
Yeah, I'll just, bang the Cgd Health drum that holding governments and donors accountable to using data and evidence to inform their programs and committing to transparency and sharing data on how they spend their resources and the results of those resource uses is really, a milestone that a lot of entities could still work towards and realize the potential of global health for all genders.
Roopa, I know you put something in the chat, but please, any last minute?
I'll be really brief. 4 points: change the narrative. 2, let's continue to gather evidence. 3, let's really make sure the gender equality is seen as everybody's business. And 4th, what I've put in the chat is let's work collectively together to really achieve a new social contract for women in the health and care sector, and more broadly for just as the theme of this entire day has been about creating more resilience and equitable societies. I've put in information about the Gender Equal Health and Care Workforce Initiative. I hope to engage all of you, and please, if there are governments particularly that you think would be willing to join this effort, we are targeting governments for this initiative. Thank you.
Thank you so much. I think Camille will take it over, but thanks Roopa, Julia, and Kristen for being here and sharing your incredible insights. That was great. Camille, do you want to?
Yeah, no. As Dr. Cates has said, thank you all for being here. Thank you for moderating as well. I think that some of the insights that you added to the conversation are really helpful, and I think everybody here probably learned a lot, and this is a really important topic, and we appreciate you taking the time to sit with us and talk about it today.